Hey guys, it's Archie. I'm back again at the ADHD Congress in the Netherlands, and I've got another special guest with me. I've got Dr. Marios Adamou, who's joining me, and he's based in the UK. Previously, he used to work for the South London and Maudsley NHS Trust many years ago, and now he's moved to Yorkshire. So we're just going to have a discussion about his journey, particularly in this ADHD world, and also how he's finding the Congress. So first of all, welcome.
Thank you.
Nice to meet you. We were discussing just before you came online there. You were telling me about this program that you're mentioning about artificial intelligence.
Yes.
Yeah.
So we created a diagnostic tool that helps make ADHD diagnosis quicker without compromising quality. So we developed a tool using AI technology and methods whereby the normal clinical data that we would have collected in the clinic gets, let's say, fed into this tool, which gives diagnostic decisions with very good accuracy. Also, this tool helps prioritize or differentiate cases which require less expertise from the clinician to cases which require more expertise.
So when you say it's a program, how does it work?
It's an algorithm that gives diagnostic decisions.
Right.
So what you do is you feed in the information you would normally take in clinical practice, which is part of the diagnostic interview, parts of the a number of screening tools, and then you feed them into this algorithm, and the algorithm thinks and gives you a recommended decision, and it's either yes, this person may have ADHD, no, it may not have ADHD, or this is a very complex case. So what we do is, the complex cases, we ask our more experienced clinicians to take more history and explore further, whilst the cases which the diagnostic outcome is clearer, we may give to less experienced clinicians because the outcome is clear. And then also what we do is we can start treatment quicker.
Right. So the information that you load into this program is basically just the patient's information, the patient history and everything.
Well, it's before the history. So we load information like the anxiety levels, mood levels, a number of ADHD questionnaires, some questionnaires relating to diagnostic interviews. So this is stuff we would have done anyway. So the patient doesn't need to do anything different. The clinician doesn't need to do anything different. But when we get a diagnostic recommendation, that's useful. So then we can use that based on how confident we are. And then if the diagnostic recommendation says, yes, this person has ADHD, there's no point in them going through another longer assessment to confirm it. We can recommend treatment quicker. So if a person has ADHD, they can have the treatment faster without compromising quality of their assessment.
Right. So how these things usually work is we sent out some pre-assessment questionnaires to the patient.
We do.
They'll fill out lots of questionnaires. Some of them are specific to ADHD. Some of them are more generalized, more kind of focusing on comorbidities, social functioning, mental health, and all of that. So these are that's the information that you.
That's the starting information. We also put information from one of the diagnostic tools many would have heard of, which is called Diva. So we input that as well.
Right.
So in combination, and for the Diva, the way we run it, it may take 2 hours, and maybe we can also talk to an informant as well to validate the score. So these together alone give us a diagnostic recommendation with 96% confidence.
Right.
So if it says yes, I'm 96% confident based on this tool that the person has ADHD, and I don't need to ask any more questions.
Okay.
So that means I can offer this person, if appropriate, treatment quicker just based on that.
So the interview that the patient would have is more just focusing on just the Diva. So that's the only questions that...
I call it a Diva Plus. So it's an expanded Diva, but it is not the full, let's say, in-depth history that a person who is more complex requires. And the algorithm, the tool, will tell you this is a case where you need to ask more. So these people will have the further appointment. But if, let's say, it's a clear-cut case, why would they go and have a even longer assessment when the outcome, 96% of the case, will be the same?
Yeah.
So
Yeah.
they get offered the treatment quicker,
Yeah.
and speeds up their experience, so they don't have to wait as long.
I get what you mean. So certainly, like me as a clinician, I do assessments all the time as well. So it will save me time, from what you're saying,
Yeah.
to focus on patients that actually need more
Yeah.
dedicated time to
Exactly.
maybe unpick some of the other complex issues that they might present with, versus clients that are more fairly settled, straightforward, that you can just give a diagnosis.
Yeah.
Certainly from the information that you've looked at,
Yeah.
and then certainly with the confidence of the AI
Yeah.
that will give you. I get you.
Yeah.
Right.
So that's what it is. Thank
Okay.
you. You had to explain it much better than I did. You see, I'm not selling it. I'm trying to describe it.
Fair enough. Fair enough.
And
Yeah.
a lot of study things get filtered through my mind until I try and get it. But thank you.
No, that's fine. So, is it like an app? Is it a portal?
It's a portal,
Right.
And the clinician who's completed the DIVA, and they have all the screening tools there. They just put the numbers in, and then the algorithm gives them the recommended decision, which either yes, they may have it, no, they may not have it, complex case, look further. And also the way we structured it, it gives the clinician some explanation around why is it a complex case. And they would say, high scores in bipolar, high scores in substance misuse, that's why I cannot tell. So you go and look.
Ah, right, okay. And then you as a clinician, then you would then do further
exactly
interviewing, speaking to the client, patient, and stuff like that.
Yeah.
Okay. Are you using this at all in your practice, in your clinic?
We are using it in a clinic.
Yeah.
It has increased our productivity, if I can use this focus, by about 20% as a minimum. It's also allowed us to bring a different type of workforce, because the layering of complexity allows you to layer the skills and expertise of the people as well. So we don't have vacancies in our practice, and from the patient perspective. And as you've seen, one of the patient groups called ADIS has supported us with feedback. The feedback was positive because patients were getting the outcome they wanted one way or another quicker.
Yeah. Do they feel assured, though, that it's... I'll come back to the BBC Panorama documentary, but if you think about it, traditionally people want to go and see someone, sit down in the clinic, be assessed for at least 2 hours.
Yes, they would they'll get that.
Oh, they will still get that?
Because that's the DIVA assessment.
Ah, right, okay.
So they would sit down, they would get at least a 2 hours assessment.
Okay, yeah.
And that information is included. It's not, and the tool doesn't make its own decision. It has to be validated by a clinician who's happy with the recommendation.
Oh, okay, well, I get it. So you still, the client is still seen in clinic.
Absolutely.
They would still have that contact
absolutely.
With the clinician.
And someone will speak to their partner or parent and take a collateral history and validate things as well. So it's not to be used as with information given as a tick box. No, the patient will have at least 2 hours of an interview.
Would you say some clinicians might become too reliant on it, maybe?
Not in the way is working, because if the case is complex, the tool says, I don't know, you look.
Yeah.
So for the yeses and the nos, it needs verification. So I guess there's always a risk of someone being over-reliant. But that's for us to assess in the future. It's the same way as when the guidelines were coming out and clinicians were saying, would we be over-reliant on the guidelines and all these things? And yeah, sometimes we are, but maybe that's a good thing because it brings standardization.
Yeah. The reason why I asked that question, because I know I don't know if you saw this QB Tech.
Yeah.
Just down there, they do QB tests. Again, if you think about it, if the QB patient has a QB assessment that's scoring high, and then you see them in clinic, chances are you going in there being swayed by QB. That's basically what I was trying to kind of get to the point about.
You're right about the approach.
Yeah.
So the tests and some other continuous performance tests, they are inputs. So that's different, and you shouldn't use the input to bias your output.
Yeah.
The decision that the tool I'm mentioning makes is an output based on the inputs, a number of inputs. So it's in a different place of the pathway. It gives you a decision having considered all the inputs, a number of them, and QB tests and other continuous performance tests are a limited type of input, if I can call it like that. Yeah. And it's a single input. The decision from this tool takes inputs from more than 9 different perspectives.
Yeah. Can you see this being used in other areas of psychiatry as well, like depression, diagnosing, assessing,
I'm sure in the future there will be a number of AI decision tools for diagnostic. Actually, there will be competing ones. There will be a market of them. Yeah. So I have this tool, decision tool, and the other one has another one, and mine is better. Yeah. And also there'll be tools that are country specific. They take cultural inputs into consideration if developed properly. So I can see that growing in psychiatry in the future quite a bit. It would be a bit like when and I mentioned that before, the clinical guidelines, when they were first coming out, and I'm old enough to remember them, there was only one, and now there are several for the same condition. So I think I can see that coming in the next 5 to 10 years.
We usually talk about malingering when it comes to ADHD. Someone who's trying to get a diagnosis and they're scoring themselves too highly on these forms. Yeah. Would that test be able to pick those patients that might score themselves highly in everything?
Okay, I wouldn't call it malingering in that sense, because if someone is purposefully trying to get something, I mean, it's anyway. That's another conversation. I guess it goes for all conditions, not ADHD, all aspects of life.
Yeah.
This tool will capture those because the tool is dependent on machine learning decisions and something called knowledge-based decisions, which is knowledge of experts. And the experts know that if some people use some scores, that means they are inconsistent in their answers, and some of the tools have inconsistency indexes in them. So it will capture those people, which would then be sent to the expert to validate. Yeah. So that's how the tool works. So if there's a person who's, let's say, giving answers that are not consistent with true ADHD, the tool will send them for an assessment.
And for the clinician that would have done the DIVA interview, they'll input the information of the DIVA into this program as well, right? And then it puts it all together.
Yeah, exactly.
Right, okay.
Yeah. It's a clever tool.
It sounds very clever.
It's a clever tool. It's a clever tool.
Absolutely. I can see that, like, people using it. Like, if you go, people go to the GP, I've got a cough, I've got chest infection. Yeah. You put all this information in the software and it tells you whether you might have a chest infection or something like that. You can kind of see that technology evolving.
Yeah.
Being used in other areas of medical health. So I'd love to see that in real practice. Certainly, like,
we can
for me to get my head around. I don't know if you allow opportunities for clinicians to
we do share it with some services. It's for adults, not children. We haven't done anything for children yet because it's a different data set and different approach as well. So each decision tool should be for each condition, and we are looking into automating the inputs so the patient can do it from their home. They answer the questions from home, and that would fit the algorithm rather than having to send things by post. They take time, and so
If anyone wants to find out more about this, is it widely available for anyone to access online?
Not yet. It's not yet because it's still let's say reserved for some people to trial, because we want to be confident and have the input from clinicians that they're happy with it before it is, let's say, has wider deployment. We're very careful about such technologies. We want to listen to people, clinicians' feedback before we are comfortable. We're confident, but we want to be comfortable as well.
Yeah, absolutely. So are you working in the NHS
Yes,
at the moment?
always, and
Yeah, okay. I know that fits nicely with the next question I was going to ask. Just get your thoughts in terms of the recent documentary we've just seen on BBC in the UK on ADHD in private clinics.
Yep.
That's being compared with NHS clinics.
Yep.
And certainly from a psychiatrist point of view who works in the NHS, who's been in this field for so many years, and I'm sure you've worked with lots of private clinics, or you know people that work in the private sector as well. What are your thoughts?
Okay, this expose was useful for the ADHD world, I think, although it has generated some anxiety among some people who would have had a diagnosis, and they have a diagnosis of ADHD, and then they say, okay, what's going on here? Is my diagnosis valid? And also some other people who have a diagnosis where they shouldn't have had it, and then they're saying, what's going on here? So certainly it had some ripple effects. I don't say the narrative as NHS versus private providers. I see the narrative as who can do a good quality assessment for a person with ADHD, and the limited information we had from the program is that some of these assessments by some private providers were not of quality that one would have liked to have seen to be able to have adequate knowledge of a person's health. So if in the future whoever does assessment for ADHD does them in a way that it would meet some standards and would be of quality, and the person gets an accurate diagnosis, then that's the ask. Places where their diagnostic rates of 100%, and I have examples of them, of over 90%, even on self-referrals, make me suspicious. And so this is the environment we're in. And this has been going after COVID.
Yeah.
Because it normalized online assessments. And it brought a lot of people on because of the demand. So there are a number of factors that generated this situation.
Yeah. And the emphasis around the duration of the assessment, I think that was the main discussion around an assessment being undertaken in 40 minutes.
Yeah.
Some assessments being undertaken in, I don't know, over an hour. And I know you can do an assessment. I was talking to a few other guests who came on this podcast a while ago. We were discussing about you can still do a thorough assessment online if it's done appropriately, following the guidelines.
Yeah.
And I think it's about the quality. I agree. I think most providers who work in the private sector also used to work or still work in the NHS. I think the message that they were trying to put across was around there are some questions around the regulation of private clinics. Certainly, I think there is some work that needs to be done around that, maybe, because there isn't any regulation, but it's how it is done. You coming from the NHS yourself, you carry out ADHD assessments day in, day out.
Yes.
I agree. I think it doesn't have to be you versus us, because I work in the private sector. I think the conversation should be around the quality assessment. Are we doing a good job for the client?
Exactly.
Are we not over-diagnosing? Because the fact that the patient's paying a lot of money to come privately doesn't then automatically mean that they're going to get a diagnosis at the end of that.
I think private sector should see, in my view anyway, the patient as a customer to please, and they should give the clinical answer that the person is paying for, even if the patient expects something else. I think there is a narrative that has been developed which might have some foundation in that because you pay you get it, and that should not be the case.
Yeah. Yeah, and certainly thorough screening, obtaining enough information beforehand also helps.
Absolutely.
So, and that's something that wasn't really highlighted in that documentary. What would you say in response to the reporter that was assessed by 3 separate private clinics and then goes to the NHS and was told that it's a no diagnosis? What were your thoughts about that? Because obviously that was quite a snapshot. We didn't get the full picture of what particular questions was asked by the psychiatrists in the NHS that the private sector probably didn't ask.
Well, I recognize the practice of the private psychiatrist, the NHS psychiatrist. This is what the person would have been asked in our service. So I would align myself with the duration and the type of questions of the NHS psychiatrist, and not what I appreciate that snapshot and limited bit of information showed. I've been working ADHD for, I don't know, since 2004-05. I couldn't feel confident in a standard ADHD assessment in anything less than 2.5 hours. And that I mean by uncomplicated cases. So the 3.5 mark is a good one. So I'm certainly supporting the approach of the NHS psychiatrist who assessed the person as the standard one.
Would you say, obviously the psychiatrist knew that there was a documentary being made about an investigation, so we have to bear that in mind as well. So
in fairness, I don't think that the psychiatrist did a longer assessment or a more thorough assessment just because the person was through a documentary. If the person was in our clinic, the person would have had guaranteed 4 hours assessment without using the let's say, what's his name, without the time for pre-reading and scoring and the rest of it. Had we not used the algorithm, if we had used the algorithm, the person would have had a minimum of 2 hours assessment, because the algorithm would have come out as no. So the person taking the pre-reading and the scoring and everything out would have had a minimum of 2 hours assessment, and if we were not using the algorithm as a guide, a 4-hour assessment. So the 3.5 to us is standard.
Okay. Anyone listening to this conversation who watched the documentary in Panorama, okay, so if you wouldn't mind outlining to us what constitutes an adult ADHD assessment that you carry out on a day-to-day.
Okay. So for any ADHD assessment, it has a number of parts. One is screening and using screening questionnaires. The other part is a validated diagnostic interview, and the other part is validating and triangulating that information with collateral history, and then taking a full history to exclude that comorbid conditions are the cause of the disorder. So first, the person needs to not have a mental disorder before one can conclude that difficulties are because of ADHD. So that this is our approach. ADHD symptoms are not in their own right diagnostic. As you will know, people with dementia have inattentiveness, PTSD, bipolar. Yep. So inattentiveness in its own right, which is a core symptom, is not in itself diagnostic. Similar with hyperactivity and impulsivity, anxiety disorders, hyperactivity. So it's not just ticking the boxes that you have the symptoms. The symptoms have to be pervasive, they have to be impairing, and they have to be clearly attributable to ADHD. So the whole process is collect information that supports this criteria. And if you can find them, then it's a yes. If you cannot find them, it's a no. So it's not certainly a 40-minute job building the case for ADHD diagnosis. People need to be respectful of ADHD as a condition, and they need to give it its due attention, and people with ADHD are entitled to that. they had this condition all their life, and the last thing you want is someone to a hurried job, and then they are left confused at the end of it. So that's my plea really to whoever provider is that. So I have no problem with any provider as long as they stick to this.
There's different perspectives from speaking to people in the NHS here. The pressure that they're also under, targets, commissioners saying you need to see X amount of patients over the next 6 months. Private providers having contracts, they have an obligation of seeing a certain number of patients over a certain duration. So I think the other message that was being driven from that documentary was around, it felt like a conveyor belt. You're just coming in, have your beat assessment or review medication, off you go. It's the pressure, the demand that's increased. So I think some of the conversation has to move away around private versus NHS to managing this pandemic that's affecting everyone, not just in the UK.
Absolutely agree.
Yeah.
However, what you should get is equivalent of what you get in the conveyor belt. So that's the whole point. You know, the idea that there's a lot more demand now. There's a lot more demand. That's what it is. It's maybe it's justified in the sense that more people know about it, more people coming forward. There's been chronic under-recognition of this condition, so there may be pent-up demand. Okay, now it's flowing. Fine. It may even be good. Why not? The word pressure, well, I understand it and I don't understand it. And I'll tell you what I mean by that.
Yeah.
If you have some job to do and this is for 5 people and you have 1 person doing it, there's pressure. If you have 5 people doing it, there's no pressure. So the pressure, there is an artificiality in the pressure. If you expand the capacity, there's no pressure. So why don't they expand the capacity and then there won't be pressure? And
I think that's the issue there. The funding is not being allocated for people to, even if there is funding, to get the right people to come on board. We've got the right expertise and skills. NHS, private, you know, that's the issue there. People end up going to, you know, get agency locums, which is obviously quite costly.
Absolutely.
So you know, we can discuss this. We can have a lengthy discussion about, and certainly speaking to Andrea earlier, again, that was what we were discussing about that. It's from a understanding that this is a nationwide pandemic that needs to be addressed.
Yeah, absolutely.
The government needs to take a recognition and understanding that how mental health services are set up.
Yep.
In thinking more about ADHD and how the impact that can have in someone's life going forward, becoming an adult, the chronic impact it can have in their lives.
Absolutely.
So, it's
well, look, a few years ago, we were debating if it even exists. So it's a new condition. We have to be very mindful that this ADHD it's a really new condition, and society hasn't quite got to grips with it. The governmental policy people haven't got to grips with it either, in fact, at all, because there's no strategy or guidance for that, for adults at least. So that's why there's this uncertainty. Last thing we want is patients not getting the care they deserve, and people using this type of opportunity in non-ethical ways.
One issue, I'll just point this out before we finish. There isn't any standardized training. I know there's a standardized way of how we assess ADHD, but if you think about autism, you know, there are all these like ADI, 3DI, ADOS.
Yeah.
People have to go and be trained to be able to conduct an autism assessment. For ADHD, there isn't. I know
there will be. We're working on a paper.
Are you? Okay.
Yeah, it's sitting on my desktop.
Oh, is it? Okay. Do you want to brief us on what to expect then?
Well, I think we need to finalize it with reach consensus amongst the experts. But it describes the components of a quality assessment and the components of a quality report as well. Because if you do a good assessment and your report doesn't show the information, then that's not the point. So we're putting some recommendations forward. and that would hopefully anchor practice to at least a minimum acceptable standard. So that's what we would like to help people do.
So are we talking about guidelines here, or are we talking about...
Yeah, it's some guidelines for a quality assessment.
Right, okay. How about a specific type training that could be...
Okay, that's a good point. As you may know, for the UK, the Royal College, which is responsible for the training, doesn't have competency standards for adult ADHD. So anybody can say, I'm an expert in ADHD. Also, as you know, there is no standards for a good quality assessment. So anybody can do anything they like and call it a good quality assessment. You can see now how easy it is in a condition where people are so vulnerable, there's so much demand for someone to call themselves an expert and call themselves their assessment an expert assessment in ADHD, and then do what, the room is quite open. You will not get that in surgery or oncology, but the opportunity exists in ADHD. Our college is, I think, yet not there in terms of describing clearly the competency standards of an expert. But in my mind, it's in the same template of training, should have had a number of cases with supervision to be signed off as competent. I know when I was approached by some locum agencies, which they didn't know that I had expertise in ADHD, by some private providers who wanted to have some locums to help them out, the only question I was asked, are you an expert in ADHD? I said yes, and that was it.
Okay.
Yeah, that did it.
Right.
They didn't know I was.
Okay.
So their standard is it's self-declaration of an expert, and that was enough to qualify you to take a place. Yeah. So I think that's
What defines an expert goes back to the NICE guidelines that they don't give a clear clarity in terms of who can assess.
They don't describe the competencies. They describe the NICE guidelines are reasonably vague. They say someone with expertise in assessing them, but they don't say what the expertise consists of.
Yes. So there is a disparity there. And they talk about psychiatrists and an appropriately qualified clinician.
Exactly. But they don't tell you what makes an appropriate qualified clinician, and they don't tell you what makes the psychiatry expert, because there's not in the scope of NICE in that sense, because that's a professional matter to determine what makes an expert. And we've put some proposals forward, and maybe we can work on them a bit more, because the issue there is for patients, there's not enough information about them choosing their provider. So if there's a private provider that's a market, the patient is not informed who is a provider with the good experts and the good assessments, and not because that information is not there for them at all to access. So if I go and buy a tire or something, I know the brand, I know the reviews, but that's not enough. I know the quality, the standards. They have that certifications that have taken place, the regulations for that thing to go and be approvable. But for ADHD, there is no such standard for me to check. There's no some regulation, so there's no accredited ADHD providers.
No.
There's no accredited ADHD specialists. So if I'm a patient, how can I choose? So the only thing people can say, well, at least if they're in the NHS, that maybe that's a way of safety, but that's not always the case. And it doesn't mean, and I'm not saying that because this is an ADHD service is good, and because that's a private provider service is bad. I'm not saying that at all, because I am sure that ADHD services which are substandard and the private services which are great. It's just you don't know which is which.
Yeah, it's a minefield as a patient, as you say, going online, trying to Google a specialist in your area to be assessed for ADHD. You get, as you say, anyone can just go up and post an advert saying, I'm a specialist. I've worked in this field, and certainly just because they've done a course on ADHD and worked in a clinic for a few months, that doesn't then constitute them to become a
But
specialist.
it doesn't stop them either.
But I suppose if you look at other trades, I've compared it with things like trades. If you want to look for a paint and decorator, or you can go on checker trade in the UK. We've got rated people, and people look at, because these people have been vetted by,
But you see, they're not regulated. These people, the traders and all these things. So you go by feedback. So you say 50 positive feedback is good. So if I'm a person who knows nothing about ADHD, I call myself an expert. I diagnose 50 people who wanted to be diagnosed and all gave me feedback. I am the best expert on ADHD in the world, despite me having no idea and misdiagnosed maybe I don't know how many. So that mechanism should not apply for medical professions in ADHD. And that's why what should apply is the standards and the regulations and the compliance to those. And that's how we practice.
So we need an accredited registered body, like what you have with the GMC or like
or
HCPC,
some Royal College of Psychiatry, competence framework, where you can say, I have passed this competence framework, and therefore I have the credentials to call myself an expert in ADHD. Simple, but necessary. Also, there needs to be a framework which says, I have followed these recommendations of what a good quality assessment report will look like, and therefore 1 and 2, patient safe on their diagnosis.
I agree, and that gives more assurance to the patient.
Exactly,
anyway.
that's the whole point.
And patients would only need to go on one particular website, if you want to call it that, where you can find all these accredited.
Exactly.
Rather than just Googling and...
the poor people, what can they do? They're desperate, they want some help.
Yeah.
They're trying to navigate through all these difficulties. And they are left in luck, frankly, about where they're going to land and who they're going to see.
Yeah.
And that's the situation we're in. And that's why this panorama thing exposed that it's possible this would happen.
Yeah.
And that was the whole point that I took.
So I think taking this forward, what would you be suggesting? Because you work, you're...
Yeah, well, I know what I'm suggesting. The thing is, I don't know if I can do it as well. So what we need to do, and I've got some competency framework for someone to be called an expert, and it's got 3 stages of expertise, and a person will need to go through these 3 stages to then be like a certified, which means expert in ADHD. And also we need to get that paper out around the quality standards for the ADHD assessments. I think that's easier to do, to guide people about what their ADHD report and assessment should look like. This guidance is not for clinicians alone. It's for patients. That's what my aim is anyway. If I'm a patient, I want to read this guidance and say, was my assessment done this way? Okay, I'm happy. So it's patient-facing as well as clinician-basic, because an informed patient is very important. I want them to have this is called market knowledge. This is what I want from my assessment. Can you give it to me, private provider? No, I'm not choosing you. I'm going to choose the other private provider who can give me this. Are you going to take this time? Are you going to do it in 90 minutes or 3 hours? Are you going to use this tool or not this tool? Are you going to... No, okay. Well, that's what I want, because I'm paying you, remember? I'm the customer, I'm paying you. So if you cannot give me what the good standard is, I'm going to choose you. And then let market take care of the private providers who are not good.
There are some regulations that will need to be done. If it's, what we're describing here, it's not about just you've vetted the service or the clinician and say, yep, you have the right expertise. It's the ongoing work that's involved in terms of, are you still? It's a bit like what CQC does.
Yeah.
So it has to be a regulatory body that's going to be. Not just like we just approve and accredit you, but we're going to keep monitoring you. That's possible.
That's
a lot
possible.
of work.
Well, I'm thinking, possible. I'm not advocating for it. I'll tell you why. The idea is not to overregulate private providers so they cannot do the job. No, that's not the point. The point is to have a set of standards where everybody agrees with, and then we all work according to the standards. And at the moment, let's say we're a company that makes widgets or something like that. And I am a company A and I make this widget and it's looking good. And I'm a company B and I use some imitation products and I make this widget. It looks the same, but it's going to break in 2 months. Yeah. It doesn't happen this because there are industry standards. And I say to you, your widget should be this and this and this and this. And if you don't comply with this, then we don't accept your widget. Yeah. So, and once you've set the standards, then the market, some providers are better than the others, they're good at some other things, there's still a market. At the moment, there's nothing to determine the industry standard for ADHD, either in who's going to assess you or how the assessment is going to look like. So there's huge inconsistency in the quality of assessments. And when you've got lots of people doing lots of things, you get lots of inconsistency, and one of these days, Panorama may show up on your door and catch it.
Yeah.
And this is what happened.
Yeah. Yeah.
So that's why I'm not making specific narratives about specific companies, because it could have been anybody anywhere, and it's a snapshot of the inconsistency that is inherent in the system that has been developed, which doesn't have the standards.
I agree. The same conversation could be moved on to counselors, therapists, who claim that they are, private therapy. I can offer psychological therapy, and I'm qualified, and I'm a specialist in this and that. Yeah. So it's a wider conversation you can then have.
Absolutely, but they don't prescribe controlled drugs, and they're not regulated by the GMC. So
of course, absolutely.
And they don't. So that's a different sector with different rules. Yeah. So they can say that, but they're not in the same.
Yeah, no, absolutely. Dr. Marios Adamou, absolute pleasure.
Thank you, sir.
Thanks for coming on to this podcast, and thanks for the interesting conversations and getting your thoughts. And we'll enjoy the rest of the conference.
Thank you.
I'm sure we'll bump into each other at some point.
Absolutely.
Take care. See you then.
Thank you.
Bye.